The content discussed in this episode may be specific to the guest's organisation or location and may not be applicable to other organisations, states, territories or countries. The material presented in this podcast is for general information purposes only and should not be considered health, legal or financial advice. Medical administration is a rewarding profession, but it comes with challenges. So what is it like, and what should you do if confronted with a monumental administrative difficulty? This is the podcast that takes unfortunate scenarios and explores the essentials of clinical governance to find solutions. I'm Dr David Rankin, a very experienced medical administrator and lead fellow with the Royal Australasian College of Medical Administrators. And this is Safeguarding Healthcare, the essentials of clinical governance. Today, financial stress and a call from the media.
Going on a headstrong mission to find out who somebody is not actually going to be the most valuable in this moment.
That's Dr Angela Williams, the Executive Director of Medical Services, Gippsland Southern Health Service in Leongatha, Victoria, and a Senior Forensic Physician at the Victorian Institute of Forensic Medicine. And I'm presenting her with a difficult scenario.
I think the very last resort is to go to media because it does bring a whole lot of risks to the organisation, to the staff, to the staffing group.
In today's scenario, your hospital is under significant financial stress. One of the services that has been identified for cost savings is the Paediatric Behavioural and Developmental Assessment Service. This service provides outpatient services to high-needs children in the local area. The rationale for the closure is that these children should be referred to the Children's Hospital. You receive a call from a reporter from the city newspaper who is keen to run a story about the impact of the service closure on local children and their families. They have clearly been well briefed by one of your hospital's senior paediatricians, though declined to say who their source of information is. I started by asking Dr. Angela Williams what issues this scenario would raise.
What a scenario, David. And one of the words you used in there was stress, and you connected that to financial stress. But I think not only are there going to be financial pressures within this scenario, there's a lot of stress for the doctors that are involved and for the system. And of course, when you connect those stresses of financial pressures and clinicians that want to do the very best by their community and their patients, it's going to raise all sorts of issues. There's ethical issues, there's clinical issues, we've got reputational issues for the organisation around media and engaging the public affairs side of things. And ultimately, at the end of the day, we have a cohort of people in community that we need to think about what kind of care we can give them. And if we can't give them, how we optimise what we do and connect with other partners. They're just some of the issues that came to mind.
Thanks, Angela. The doctors are a passionate group of clinicians. They provide a highly regarded service. How can you as a medical administrator balance this clinical passion with the financial constraints of running an organisation?
Oh, David, I think you're talking about that commitment to advocacy and courage that the clinicians will bring with the passion, but also that potential disruption to the environment around when something's going wrong, and for them, the ability to deliver good services. And essentially, it ignites a concern of the significant risks to the organisation, not only from the practitioners, but of the clinical care that we can give. But we have to balance that, as you suggest. And the challenge, therefore, is to understand those financial constraints and budget limitations and sharing that information with the doctors and the rest of the hospital and how we face it, but in a way that continues with optimism and the ability to connect to the services rather than fear and concern. We've got to look at it, analysing that financial data in a way that can be communicated well to the medical team, and that we're transparent in our decision making, and we engage those, especially those that are really passionate about their service, in discussions about the financial limitations that we indeed have.
So the paediatricians are concerned that the local children won't have access to what they perceive as a vital service. The paediatricians see the flow-on costs in education, social services and later healthcare costs, whereas the organisation tends to focus on just the delivery of the health component of that service. How can we balance this need to look at the wider issues of the child versus the services that the hospital is specifically funded to provide?
It's a really important question, because we're really balancing the clinical needs with those financial pressures, and it extends sometimes well beyond the organisation. So we're going to have to engage the stakeholders, involving the paediatricians, community health services, any other sort of stakeholders that might assist in the discussion about any sort of service change. Ultimately, the clinical needs of children are going to be right in the forefront of our minds. So how we clearly articulate that and consider it in the decision making. And decision making itself needs to be data driven, doesn't it? And have really true quality measures and outcomes that we're all aligned with. And so how we present the evidence of how we access the paediatric services, if you like, and how it affects the education or the social services and the future healthcare of the children's really important. We might want to advocate together at some stage with the paediatricians in looking at what alternative sources of funding might be available, shared funding models, partnerships, collaborative funding models, private models. There's all sorts of different ways we could look at this as well, especially if we engaged in some collaborative and evidence-based discussions. I think this scenario really is based around clear communication.
I'd like to come back to that whole philosophical issue a little bit later, but the immediate issue is that the press has called you, media's called you, and you want to try and work out which is the doctor that's talked to them. How would you go about identifying the doctor who's leaked the story to the press?
Well, I've really tried to think about this question, David, because going on a headstrong mission to find out who somebody is not actually going to be the most valuable in this moment, I don't believe. I think what we've really got to do is approach this situation with some empathy. I mean, people have been really troubled by some decisions and have felt they haven't got any other pathway of openness and connection to the organisation, or even my role in this particular scenario. And that needs to be approached, as I said, with some empathy and some clarity and some support. We've got to rebuild the trust and morale, and this is a challenging time. Headhunting for a particular person, I don't believe, is the right way to go about it. And I think with open communication, it'll probably foster some interest from the right people and certainly engage clinicians in a way forward.
I agree. Going to the media is often a last resort for doctors. What steps would you have liked to have seen in place in your organisation to potentially avoid the doctors feeling they need to go to the media?
I really hope it is the last resort, and the culture of the organisation ideally will be one where any clinician feels that they can talk about a problem, concern or a risk, especially those pertaining to patients and community, and escalate up their chains. And so in order to do that, you have to foster that environment of openness and a just culture of reporting, transparency, data-driven connections. And when you build that reputation throughout the organisation, hopefully there is some alignment. There's some transparency in the decisions, and people can connect with what decisions are made together. So I would hope that if somebody had concerns, they were able to go through whatever chain it is and certainly come to the DMSs or equivalent, CMOs, EDMSs, etc. And beyond that, there are avenues through to the CEO. I think the very last resort is to go to media, because it does bring a whole lot of risks to the organisation, to the staff, to the staffing group. I mean, media impacts the doctors themselves, the service they're delivering, and gives community that sense that something might not quite be right, and therefore you lose the patients and the clients to the hospital too.
That's a real challenge for medical administrators. So often decisions like this are made at budget time, where the executive team will go through line by line and decide what is high value or low value, and make decisions about cuts to service without perhaps engaging the frontline staff. So the role of the medical administrator. You are party to the discussions at the budget meetings. What's your role in trying to head off a situation like this?
My role is to communicate the difficult decisions and do that in a way that's sensitive, transparent, and has a really clear plan. And I think to do that, I would really need to understand the decision itself and be very clear on the reasons, including the financial constraints and the impacts on the hospitals and any other alternative options that were considered at the time, and anticipate the concerns of the staff and perhaps arrange a really dedicated meeting to discuss the decision. Try and maintain some alignment, of course, to the organisation, but it's that interesting space that the DMS often sits in, isn't it, between the operational group and the executive decision making. I want an open dialogue, and I really want to involve the key leaders.
Some of these meetings are very contentious.
Yes. I think the thing is, though, that if you listen to people, especially people who have alternative views or are clearly passionate and interested in the outcome, what you hear doesn't necessarily have to align with where you're headed. But these people are really going to be the doctors that help you out with the risks of the decision that's being made. So it's incredibly important to be transparent and honest, but listen and acknowledge the impacts that might come as a result of the decision, and be ready to review that as necessary.
There are some clear steps laid out in legislation about whistleblowing or going to the media about contentious issues. At what stage in the discussion with the doctors during contentious meetings would you sort of point out that they have a right to approach the media, but there are some preconditions to being able to exercise that ability?
Yes. I mean, each organisation is likely to have its own policies about accessing media, and I just really encourage people to have a look at those, because there can be reprimands and sanctions for doing so if it's a breach of hospital policies, etc. However, people do get to a point where they feel they need to whistleblow on decisions that have been made, largely in the sort of fraud or concern for public safety space. And so I think that staff should definitely understand their pathways to being able to report when they have an issue that they really need to escalate.
You talk about sanctions and constraints. What would be some of the sanctions and constraints that could be imposed on this doctor that's apparently breached hospital protocol?
Well, breaching the hospital protocol might invite some pretty difficult sanctions, all the way at the top end of disciplinary action and, restricted access to the workforce and workplace, etc. Most of the time, I believe, if people have followed the right pathway and have connected on an issue in an ethical and the right way, whilst breaching the policies, they're probably going to follow more formal reprimands or discussions with HR or their DMS, etc. When it comes to the legal choice of whistleblowing and public interest disclosures, The media is not the first choice in that space. There are spaces within each state where people can follow that pathway. And of course, it's very important that every organisation has a whistleblowing and a public disclosure kind of policy itself, and that would guide staff to their obligations and their protections of doing so.
So you go back to the group of doctors, talk to them about their frustrations. How do you negotiate or explore opportunities that might enable the service to continue, even though the hospital may not be funding it?
Well, this is really about open dialogue and acknowledging the situation we're in and recognising some of the courage that people have had to follow that passion. It's about hearing the concerns and acting on some of them, or at least addressing them. And when you listen to people, you will hear their interest. When you hear their interest, you can work on that negotiating of more opportunity or better opportunities. And I think this whole scenario is really about fostering a better culture and some more connection. So I'd be really interested in hearing what the specialists in this area have in mind about how we might navigate some alternative solutions, some connections and partnerships, perhaps even outside the organisation, or whether there are other ways that they can continue in this care that's aligned with the organisation, but perhaps in separate financial modes.
I agree. So often we think just because the organisation has decided to cease funding the service, that service has to end. We've suggested in the scenario that it's the responsibility of the Children's Hospital to run this service, and perhaps there's opportunity to negotiate. Going to the media can be quite a courageous decision by a group of doctors, and that decision's often made by the group rather than an individual. This creates quite a rift between the organisation and the group of doctors. How do you, as the Director of Medical Services, repair this relationship with this enthusiastic, passionate group of doctors?
Really important. And I think we've already talked about it today, but acknowledging the courage that it's taken for people to speak up and speak out and addressing their genuine concerns, if you like. We've also got to talk through the media engagement and how that'll move forward so that we can repair or address or capitalise even on some of the media attention. I'd like to hold a meeting and really speak with the paediatric group, not only to address that media aspect, but also acknowledge and search for the impacts that it might have had on the team. These things aren't easy, are they? And I think in doing that, we'd create more space for the open and honest connection and collaboration. Importantly, it's the listening. I think where people have got to that point where they've had to address their concerns publicly, even if it was anonymously, they've got to a point where they are frustrated and impacted by the decisions that are being made, and we have to reconnect. We have to reconnect and demonstrate together that our decision-making processes are collaborative, that they connect, and that they've heard some of the concerns of the organisation. I think that will go some way to build or rebuild some trust, but it doesn't really stop there. You've got to demonstrate support and be collaborative on solutions. Repairing the damage this may stay for a while. It's not an easy fix. To restore that sort of collaborative culture, I think, would benefit most decision-making in the future, or any ability to carry out new and improved projects. Ultimately, the quality of care, especially for children and young adults in the paediatric system, but really everywhere we work, is incredibly important.
A really difficult issue where financial decisions by the organisation come into conflict with doctors' passion for what they believe is an important and vital service for your hospital. Do you have any final thoughts on the concept of whistleblowing and clinicians' ability to express their concern?
Absolutely. Whistleblowing itself is a really critical mechanism that we can ensure accountability and transparency in healthcare. But it needs to be handled with care and support and the balance of protecting those who raise concerns with seeking an outcome and the need for really stable and connected, effective working environment. It's a very difficult space, David, and I think it's worth reiterating that this stress will be right throughout the organisation, not least of which will be through the doctors who care, and therefore how to support them and engage them back would be the heart of this issue.
That was Dr. Angela Williams, the Executive Director of Medical Services, Gippsland Southern Health Service in Leongatha, Victoria. And that brings us to the end of this episode of Safeguarding Healthcare. I'm Dr. David Rankin. Follow Safeguarding Healthcare free on Apple Podcasts, Google Podcasts, Spotify, or wherever you listen to podcasts. This podcast is produced by Sound Cartel for the Royal Australasian College of Medical Administrators.